Assalamualaikum.
Salam doktor.
Cukup dah ke semua?
Salam doktor.
Ha?
Cukup dah.
Dah cukup dah.
Cukup dah. Okey. Sekejap bagi saya 5 minit Kejap ni. Sekejap. Okay, kita mula dengan umul kitab Al-Fatihah. Alhamdulillah. Assalamualaikum. Okay, Assalamualaikum warahmatullahi wabarakatuh. Sorry, session yang petang ni topik apa? Apa topik ni?
CP.
Apa dia?
Case presentation.
Okay. So let's start. Siapa nak present?
Saya yang present first, doktor.
Okay. Please proceed.
Okay, my name is Aini Salaha. So my patient, Nur Ayuni, a 10-month Malay girl, was brought to emergency department with a chief complaint of rapid breathing for 1 day duration. Okay, for history of presenting illness, the rapid breathing was preceded with cough and fever, which were 4 days duration. Regarding the cough, it was productive with greenish sputum. There is no blood stain, and there is no barking cough. There is no prolonged bouts of cough followed by high-pitched inspiration. There is no barking cough. This is to rule out croup, and no prolonged bouts of cough followed by high-pitched inspiration to rule out pertussis. There is no stridor, choking, and changes in voices to rule out upper respiratory obstruction. She also had post-tussive vomiting, in which she vomited 3 times in that day. The vomiters are sputum and partially digested food, approximately about 1 cup. Apart from that, she also had fever. The temperature noted was 38 degrees Celsius during the day, and around 40 degrees Celsius at night, because the mother had the thermometer at home. However, the fever was not associated with chills and rigor, and it was not relieved by tepid sponging and syrup paracetamol. Other than that, she also had loose stool occurring at the same time, which was also 4 days duration. It was watery with no solid pieces. It was yellowish in color. It was large in amount and had soaked the diapers, and it sometimes overflowed the diapers. And the mother needed to change the diapers 6 times per day, which was usually she only need to change the diapers 3 times per day. However, there is no mucus or blood in the stool, and due to that, the infant was less active as she slept along the day. However, she can still tolerate orally well. Okay, and the mother denied any history of taking outside food. There is no similar symptoms among family members. There is no recent change in milk type, and the mother also stated that the bottle hygiene is good, because the mother would sterilize and cleanse the bottle every day by using hot water and warm water, and she also had a clean water supply at home. Okay, so that's all for the history of presenting illness. For past medical history, she was admitted at the age of 1 month old with a similar presentation. She was admitted about 1 week. The mother was told that she had lung infection. She was treated with antibiotic and discharged after that with no complications. For birth history, she was born term at 38 weeks of gestation through spontaneous vertex delivery. The birth weight is around 3.2 kilogram, and it is not. She's not admitted to an ICU. Rather, despite the one except that 1 month old. Okay, sorry. For nutritional history, she was exclusively breastfed up until 6 months old. Then she started weaning. She also regarding the nutritional, the mother also add formula milk to her diet. And for immunization history, she completed the immunization up to her age, and there is no severe anaphylactic reactions following the vaccination. Okay, so for my that's all for the history. So do you have any questions?
Physical examination tak ada?
Ada. For physical examination, it was done at day 5 of illness. She was alert, conscious, not in respiratory distress. There is no abnormal breathing, no audible wheezing or stridor, no cyanosis, and she was normal with well-nourished body. Hydration status was good, evidenced by capillary refill time less than 2 seconds, moist mucous membrane, and good skin turgidity. There's also no sunken eye. For vital sign, the blood pressure is normotensive. The respiratory rate is tachypneic, which is 45 beats per minute. The normal is 30 to 40. The temperature is 37.8, which is febrile, and the pulse rate is normal, which is 120 beats per minute. And for respiratory examination, upon inspection, the chest showed no deformity. And since the patient is 10 months old, palpation and percussion was not done. For auscultation, however, there is a vesicular breath sound, normal air entry for both sides, and there is generalized rhonchi, and there is no asymmetrical of chest wall, because if infection such as pneumonia, we expected that there is a reduced chest wall movement on one side, which suggests consolidation. Okay, so my provisional diagnosis would be mild bacterial pneumonia, because the patient presented with respiratory symptoms, which are cough, which are productive cough,
Alright, Miss, can you give your summary, provide a summary, like 2-3 sentence summary, baru you bagi you punya diagnosis.
Okay, sorry. So my patient Aini, 10 months old, infant, presented with a chief complaint of rapid breathing associated with productive cough, fever, and then a productive cough and fever. Apart from that, she also had history of recent history of hospital admission, which is due to bacterial pneumonia. However, there is no stridor, choking, changes in voice to suggest upper respiratory obstruction. She also had loose stool. However, there is no history of taking outside food, no similar symptoms, and there is no recent changes of milk type. And upon physical examinations, the physical examinations reveal tachypneic, increased respiratory rate. However, there is no respiratory distress, no abnormal breathing. On auscultation, only reveals generalized rhonchi.
Your diagnosis?
So my provisional diagnosis is mild bacterial pneumonia, because the patient presented with respiratory symptoms such as cough, rapid breathing. Cough is greenish in color, which suggests bacterial infection, and then she also had symptoms of infection such as fever, evidenced by the temperature at the ward 57.8, which is high grade. And then she also had a systemic manifestation such as diarrhea. So probably this patient might have atypical, could be atypical pneumonia. However, as we know, the most common would still typical pneumonia. And apart from that, she also had previous history of bacterial pneumonia, which require admission about 1 week. And my differential diagnosis would be acute bronchiolitis. This is because the age is 10 months old, which still valid for acute bronchiolitis. And she also had symptoms of respiratory, which is cough, rapid breathing, fever. And then upon physical examination as well, it reveals rhonchi. However, for points again for acute bronchiolitis is for acute bronchiolitis, usually the patient will be presented with mild coryza and low-grade fever. However, in this case, the patient has high-grade fever. And then, yes, that's all for acute bronchiolitis. And then the second differentials would be acute gastroenteritis. Because the patients fulfill the criteria of AGE, which is increase in frequency of bowel output at least 3 times per day, or the LUS2 exceeds the normal the normal bowel output for this child. Because for this child, usually the mother had to change the diapers 3 times per day. However, at this current situation, the mother had to change the diapers 6 times per day. And then for the points against for acute gastroenteritis is the predominant symptoms is respiratory, and then the family member is not having similar symptoms. The patient is not taking any outside food. There is no recent changes in formula meal, or and the mother also had a clean water supply. And then my next differentials is foreign body aspiration. However, the points for is because the patient presented with acute onset of rapid breathing for 1 day. And the points again is there is no history of choking, no evidence and notice by the mother of recent ingestion, and no vomiting. That's all.
So is that all?
Pardon, doctor?
Is that all?
Yes, for differentials.
Okay, good. Okay, okay, Izzatul Husna. What is good about the presentation?
What is the apa soalan doktor? Tak dengar. Comment.
Oh. Any good comments on the presentation?
Okay, for the I think Aimi elaborate full of the symptoms since patient having a fever, and then it covers fully about the symptoms, and then
Okay tak?
itu cukup.
Okay, Nurina Imani.
Yeah, Doctor. The good points for Aimi presentation that she described thoroughly the presentation of the child, and also she gave wide variety for differential diagnosis of that involving many symptoms. Okay,
good. So Ashraf Harin, what can be done better? what can be improved?
Okay, first I recommend the good one. So she mentioned she ruled out the lung threatening first, upper airway obstruction. So it's good. Seems to be better for me because patient has fever, so she can put is there any complications such as seizure? Because fever can cause febrile seizure. And then yeah, I think okay, that's all.
Najira Jamaluddin.
The good thing about Imi's presentation just now, I've noticed that she mentioned about the description of the presentation of the patient thoroughly, and then she also cover many differential for things to be added. I think maybe she can include the COVID-19 in regards to the current situation, and then to roll out other differential that can cause rapid breathing, for example, the asthma or the heart failure
Okay.
symptoms.
Okay, good. Okay. So in general, that's a very good presentation. I think it's okay lah. Yeah. I think the HOPI is okay. It's detailed enough for the audience to make a diagnosis. And then, but I agree with your friend. You have to include risk assessment for COVID lah in your history. Okay. Like, for example, like contact or traveling history, or even vaccination. And then, there's few things that I'm not so clear with. For example, you've mentioned the cough is greenish. What do you mean cough is greenish? Does it mean it's a productive cough with a greenish sputum? Then you have to clarify that, okay? And then you've mentioned the fever is high grade, kan? Tapi you cakap it's only 37.6 degree, kan?
37.8.
37.8 kan? That's not even a fever lah. Okay, 37.8 is the borderline for fever. So it's a mild grade fever, okay? It's a mild grade fever. High grade fever is 38.5 and above. And that's what we call high grade lah. Even 39 boleh kita high grade. Kalau 38 is considered low grade as well. Still. And then for vaccination, you can add on for vaccination history kan. Baby ni the patient lahir bila ni? This is your case or previous punya group case?
Previous group case, tapi ada banyak yang tak lengkap sangat. So
Okay. I think that's a challenge kan. That's a challenge. It's okay lah. But in future kan, whenever you take history, especially things yang you may related to infectious kan. So vaccination history is very important. Especially kalau macam you can mention about pneumococcal lah. Previously pneumococcal is something additional kan, extra. But now it's incorporated in the national immunization schedule. So it's okay lah. You have to mention vaccination up to berapa month. And then what else tadi? Oh yes, family history of asthma. You have to detail out. Okay, history of atopy, asthma. And then you did mention this is the second episode of pneumonia kan? Patient had episode of pneumonia in the past. So that's very important. That's very important because if patient got 2 episodes of pneumonia in a year, bacterial pneumonia in a year, there's a risk for primary immunodeficiency. So you have to think of, is the child got something wrong with the immune system? So that's very good. So that's why whenever you mention a history of previous infection, especially in last 1 year lah, in the last 1 year, it's good for you to mention, did the patient require antibiotic, or is it IV antibiotic? Okay, is it require intensive therapy macam ICU admission or non-invasive ventilators and things like that? Just summarize a bit on the previous admission. Okay, otherwise, I think it's good. Overall, that's a very good presentation. But you can improve mainly on especially on the summary part. Because summary is as the name means, it's a summary lah. So I this is semua susah nak cakap. Anyway, you have to summarize properly. The summary should include things that is important, positive, important, and important negative. Your summary, before you start your summary, you should already have your differential. So you present your summary with your differential and also your working diagnosis in mind. Okay, for example, what is your working diagnosis? Just now pneumonia, So your summary should start. I've clocked mother of Aimi. Aimi siapa nama Mother of Auni, 10-month-old girl. Because now you've got pneumonia in your brain, You want to sell pneumonia. So you have to lay out what are the symptoms and signs that suggestive of bacterial pneumonia. So you can say, so I've clocked mother of Auni, 10-month-old girl, with previous history of invasive, with severe history of hospital admission for bacterial pneumonia. Ataupun if you think this is asthma or atopy related, then you've mentioned with strong family history of atopy, okay, or with previous history of requiring nebulizer, nebulized salbutamol or nebulized bronchodilator, and then who presented with acute onset of shortness of breath. Okay, acute onset of rapid breathing associated with greenish sputum and high-grade fever. With otherwise, she is still active and there's no evidence suggestive of upper airway obstruction. Okay, on clinical and from history. Okay, dah, itulah. So from your summary, so we know you are thinking about bacterial pneumonia. You've mentioned about the greenish sputum, and then high-grade fever. So we know this is bacterial pneumonia. So you are selling bacterial pneumonia. On top of that, you rule out more important differentials such as upper airway obstruction, upper airway obstruction, and then you rule out atopy. So you do, I mean, it shows that you think about the atopy lah, asthma and its kind. You faham tak? Okay, I nak you try to summarize again. Okay, try to summarize.
Me? Okay. I've clocked mother of Auni, 10-month-old Malay girl with previous history of bacteria pneumonia, admitted at the age of 1 month old, requiring antibiotic, currently presented with acute onset of rapid breathing associated with greenish sputum and fever. Apart from that, there is no evidence of upper respiratory obstruction, clinic on history and on physical examination.
Boleh tu, that is exactly what I'm saying. So that's not, itu tak fair lah. Well, okay lah, fine. Okay, fine. That's how you do it lah. Because at the end, the summary is to get the audience back to focus, because at the end, you have to have an agenda lah. When you present a case, and you need to have an agenda. Okay, at your level, your agenda is just to get diagnosis right. Tu je your agenda. It's not about suggesting a management plan, or it's not about arguing with others, or I mean disagree with findings or with any clinical decision, things like that. So because your agenda is only to deliver what you think the diagnosis is, then your summary should focus on that. Okay, the first part is a important background of the patient. The second part is information both in the physical examination and in the history that support your diagnosis, your working diagnosis. And the third one would be the important negative that is important enough to rule out other possible differential diagnosis. Okay. So yang tu sebab because your diagnosis is bacterial pneumonia, and also your differential is upper airway obstruction kan, foreign body obstruction or upper airway obstruction. So how about others? What do you think the diagnosis is? Any other diagnosis? So the summary will reflect what you're thinking now. Because if that's your summary, then I won't penalize you for your diagnosis. But if you give that kind of summary and then your diagnosis is different, then definitely there's something wrong. You found out. So anyone have any other diagnosis in your mind? Anyone want to offer a better diagnosis with better differential? Yeah, I would differ lah. I would propose a different diagnosis. If it is me, okay, I would diagnose the child of having bronchiolitis. Okay, with another differential would be viral induced wheeze or recurrent episodic wheeze lah. Episodic wheeze would be my differential diagnosis. Because last time, cuma in this year I need to clarify lah. In the previous admission kan, did the child need nebulizer? Did the child need bronchodilator during the previous admission?
It's not stated. It's only stated that the child completed the antibiotic.
Okay, how about this time require bronchodilator tak? Dia ada bronchi kan? I presume dia require bronchodilator lah. Okay, because this child got bronchi, okay. So the diagnosis would be I think the best diagnosis, the working diagnosis should be bronchiolitis lah. So this is an active child with migraine fever kan. Then my summary would be different lah. So my summary would be I club mother of only 10 months old girl with no family history of atopy and no previous episodes of nebulization, who presented with acute episodes of rapid breathing preceded by a few days history of prodromal symptoms. Otherwise an active child with migraine fever. Clinically, okay, there's no history suggestive of pneumonia, suggestive of bacterial pneumonia, such as high grade fever or severe respiratory distress, things like that lah. And bagi tadi history. Macam tu lah. Sekejap tu lah, I'll stop there. Okay. So and then I follow, and then after summary, you continue with your differential. Okay. Therefore, my differential diagnosis would be acute bronchiolitis, supported by the presence of supported by the history of acute respiratory distress in an active child associated with prodromal symptoms such as low-grade fever, runny nose, and cough. Okay. And then on top of that, clinically, patient has additional breath sound, including bronchi, and tapi vesicular breath sound kan, such as bronchi, macam tu lah. Okay. My other differential diagnosis would be viral pneumonia ataupun viral induced wheeze. Things like that lah. Okay. You faham tak? So your summary will guide your diagnosis. Okay, ada soalan? Okay, ada soalan? Tak ada? Okay, cuma COVID at this time around kan, then COVID is very important, so you have to mention COVID. Maybe you should include COVID. I mean, in some cases, you may need to include COVID risk assessment in your summary as well. Okay? Ada soalan?
Doctor, how do we diagnose tracheitis?
Apa dia? Tracheitis.
Is
Okay,
it
what is trachea?
okay?
What is trachea?
Trachea is trachea is upper airway obstruction, upper airway tract.
Trachea is upper airway kan? Okay. You've got atas kan, you've got you punya pharynx kan? Pharynx, nasopharynx, pharynx, and then you've got your trachea kan?
Yes.
And then lepas trachea dia apa? Trachea ends up dekat mana? Trachea ends dekat?
Carina.
Ya ke trachea ends dekat carina? Yelah betul lah, trachea ends dekat carina kan? Okay. You ada you punya what you call it? Larynx kan? Larynx ends dekat you punya ni lah vocal cord. And then distal to your bronchial cord, your vocal cord is your trachea, and then carina, and then you punya main bronchus. Okay. Tracheitis ni is inflammation of your upper airway. Anything above your vocal cord is upper airway. Below vocal cord is actually lower airway. Cuma trachea ni we don't call it a lower airway lah, because it's still a large airway kan, so we don't call it lower airway. Lower airway is something yang dekat dengan parenchyma lah, dekat you punya lung, intrathoracic. So kalau you nak kata tracheitis, okay, because it's a big airway, you expect the symptoms would be more to like noisy breathing, upper airway punya sound lah. Cuma because dia at the level of below your vocal cord, usually the stridor is both expiratory and inspiratory stridor. Dia akan ada inspiratory stridor as well. Yes, because stridor can be expiratory kan. Most of stridor is inspiratory. Usually this is upper airway lah, dekat you punya larynx level. Tapi when it's slightly lower, you akan dapat inspiratory and expiratory stridor both. Okay. And then usually tracheitis ni, because it's inflammation, it's quite localized there, and you got the symptoms of sore throat, problem with biasanya sakit sore throat lah, more than upper airway, coughing rather than lower airway punya rapid breathing tu is rare lah. Okay.
Doctor, what about asthma? Because she only coughed about 4 days. So is it still relevant for asthma?
You diagnose asthma at 10 months old?
No.
What age do you diagnose asthma?
More than 5 years ago.
See? So you've answered your own questions. So more than 5 years old.
Okay. But for the differential,
you cannot put asthma as differential.
Okay.
Because asthma, you have to understand the definition of asthma. What is definition of asthma? Anyone? By the way, kenapa you guys ada 5 orang je?
Group 3 5 orang.
Sepatutnya kalau online class boleh combine few groups kan? I think that's more efficient kot. Anyway, so tak apalah. So what's the definition of asthma? Izzatul dah ni.
Acute, reversible,
Acute.
Irreversible airway inflammation.
It has to be chronic dia mesti chronic. Okay, acute is not asthma. Kalau EBA yelah, kalau EBA acute exacerbation then is acute. Tapi asthma itself is a chronic condition. Okay, so it's a chronic reversible airway
Obstruction.
Okay, so it's chronic reversible airway obstruction. Okay. Kalau dia acute reversible airway obstruction, dia apa? Biasa anaphylaxis lah. Anaphylaxis is acute reversible airway obstruction. Tapi asthma is a chronic. So bila chronic, it has to be longer than 2 years. That's what the previous asthma definition. Longer than 2 years. So you don't diagnose asthma at 10 months old. Okay, unless kalau there's very strong family history, and unless number one, you are a pediatric respiratory physician. Okay. Number two, you memang very certain. For example, you buat skin test, LZ skin test positive, test for aero allergen positive, the reaction to aero allergen is positive, very strong family history, and very frequent requiring nebulization, and you demonstrate reversibility. Okay, you boleh demonstrate reversibility by any methods lah. So problem dia bila baby kecil, you cannot do peak flow. So if you cannot do peak flow, it's very difficult to demonstrate reversibility of the airway obstruction, because you measure airway obstruction by peak flow or by pulmonary function test. Kan? Problem baby kecil macam you nak suruh dia tiup peak flow. And pulmonary function test pun you tak boleh buat baby kecil 10 months old. So never diagnose asthma in 10 months old. In fact, in your differential, maybe kalau it's very obvious, then you boleh put in your differential. But my advice is no. Okay, 2 years and above, you boleh consider. Less than that, no lah, never. Okay. So next, 7%.
Doktor.
Kejap ada phone call sekejap . Hello, Manisa. Okay, ejak. Ada soalan ke?
Saya ada, doktor.
Aha.
Saya nak tanya, in this patient, dia tak buat sputum culture and sensitivity investigation. Dia just buat basic blood investigation, lepas tu chest x-ray. But then dia tak buat sputum culture and sensitivity. So biasa kan kita bagi antibiotik kan based on agent dia kan. So tapi so macam mana? Ke just kita treat?
Kita tak macam tu. No, it's not like that. Most of the time we don't give antibiotic based on the culture, because in pneumonia, okay, the best culture is lung biopsy. That's the most specific culture untuk pneumonia. If you want to culture pneumonia, if you want to treat pneumonia, you want to certain what is the causative organism, you kena buat either pulmonary lavage, you buat lavage of the thorax of the pulmonary, ataupun you buat biopsy. You buat punch biopsy, atau you buat biopsy of the lung lah. Baru you boleh kata what is the organism, baru you boleh certain. So that's not practical lah in pneumonia. That's number one. Number two is, kalau you ambil blood culture, the yield is very low, especially in young baby macam ni, is only yield up to 10% je maximum. Okay, maksud dia, you buat pun, kalau you buat pun only 10% je yang akan dapat balik culture positif. Okay. Tu kalau blood. Kalau you ambil sputum, problem dengan sputum ni, just imagine you ada baby, you nak ambil sputum macam mana? They cannot expectorate kan? And then sputum, problem with sputum kan, it may come from the upper airway. So it doesn't actually reflect your lower airway infection. Contohlah air batuk kan, so air bagi kahak. Okay, you may get organism, macam-macam organism you can get. But it doesn't mean you are infected by that organism, because this can actually be colonizer. So you don't treat based on the culture, especially not in pneumonia lah. In most of the infectious disease, you treat empirically, tahu tak? Empirical treatment, tahu apa maksud dia? Empirical treatment ni is basically a guess. Okay, it's a intelligent guess. So you guess based on the most common causative organism. Kalau pneumonia, based on the clinical presentation, age, kan, and then the local data, what you think is the most common causative organism? Okay, kalau typical CAP kan, community acquired pneumonia, then we know the most common is gram positive, like strep kan, strep pneumonia. So you cover with gram positive lah. And then you take culture. Kau nasib you baik, you dapat lah something. Which is most of the time nasib you memang takkan baik lah, you takkan dapat apa-apa. Tapi kalau patient after you start the empirical antibiotic pressure response, then you continue lah. It's not a routine practice untuk hantar culture, sputum culture or flame the culture. Except in the case macam TB, where you know the yield is very high. Kan, and then they determine you punya prognosis. Itulah. Okay.
Okay, doktor. Thank you.
Okay. Lagi soalan? Okay, next apa?
Saya. Okay. Okay, Iman, 8 months old baby boy presented with fever for 4 days and rashes for 3 days duration. So for the history of presenting illness, he was well until he developed fever for 4 days prior to admission. On day 1 of illness, the mother noticed that the child was warm to touch and it was sudden. The documented temperature at home was 39 degrees Celsius. It was also persistent and do not resolve after tepid sponging and consuming of 5 milliliter syrup paracetamol. Then on day 2 of illness, mother noticed some rashes on his child's nose and spread to the back, abdomen, bilateral hands and legs, and to the whole face, sparring the cheeks. There was also rashes at the diaper area. The mother described the rash as feeling bumpy and denied sandpaper-like texture. The rash was red in color, warm to touch, and disappeared when pressure was applied. It is not itchy, painful, and did not contain pus or fluid. Mother also noticed that there is mild redness over his conjunctiva. There was neither eye pain nor eye discharge. There was also redness and induration of the BCG scar on the left arm. On top of that, the mother claimed that her child also had cough that was sudden and chesty in nature. However, there was no post-tussive vomiting, no whooping or barking cough. The child also had reduced oral intake as he refused to eat his regular meal. He's only taking 5 to 6 spoons of porridge and drank only 1 ounce of milk per day. So on day 3 of illness, mother noticed that his lips was redder than normal. There was also minimal bleeding due to dry and cracked lips. So on day 4 of illness, the child developed loose stool. Normal bowel habit is 2 to 3 times per day, but since he was ill, it increases to 6 to 7 times per day. The stool was greenish in color, watery with mucus, with no foul smelling, and stool did not overflow from the diaper. Otherwise, the child had no sick contact with ill person, no recent history of jungle trekking, swimming, or direct contact with rodent. Also, they are not living in a dengue-prone area. So, worried of the child condition, the mother brought her child to Hospital Muazzam and was later transferred to HTAA for further assessment. So, for past medical history, this was his second hospitalization, where the first hospitalization was due to presumed sepsis and was admitted to SCN for 4 days. Otherwise, he had no other known medical illnesses. So for birth history, the antenatal history was uneventful. For intrapartum history, he was born full term at 38 weeks via vacuum-assisted delivery due to fetal distress. Birth weight is 3.35 kilogram. Postnatally, he developed neonatal jaundice for 3 days. For immunization history, he had completed immunization up to his age. No allergy reaction post-vaccination. So for his developmental history, he had normal development and which correspond to his age. So for diet history, he had exclusive breastfeeding since birth up to 1 month old. He drinks formulated milk from brand Lactogen. He drinks 4 ounces of milk for 3 to 5 times per day. He starts weaning at 6 months of age, where he was given porridge 2 times per day and fruit puree. So for drug history, he is not taking or given any medication, supplement, or traditional medicine. He had no known drug allergy. So for family history, he is the only child in the family. Father is 27 years old and the mother is 26 years old. Both parents had no known medical illnesses. Social history, they live in Bandar Muazzam. Parent work as a money changer officer. They always bring their child together to workplace with them. So for the physical examination, so for general examination, the child was alert, comfortable, sitting on the bed with his mother. The child looks lethargy, mildly dehydrated, evidence with dry lips, fissured lips. Pharynx and throat was injected, and hypertrophic tonsils was noted. Good oral hygiene, no pharyngeal petechiae, white spot inside the cheeks, and oral ulcer. Tongue not coated and not swollen, resembling strawberry tongue. There is bilateral non-purulent conjunctivitis and macular rashes at the trunk, face, and minimally at the back. Capillary refill time was less than 2 seconds, and there is normal skin turgor. There was also multiple palpable lymph nodes. So for vital sign, the child was febrile with 37.9 degrees Celsius. Blood pressure was normotensive, respiratory was normal. Pulse rate is 170 beats per minute. Otherwise, other systemic examination was unremarkable. So for my summary, I have clerk mother of Iman and an 8 months old baby boy. Presented with fever for 4 days and rashes for 3 days duration. The rash were macular and associated with bilateral non-purulent conjunctivitis, red, dry, and fissured lips. He also had cough, diarrhea, and poor oral intake. Otherwise, there was no edema and erythema of hands or feet and transient arthritis. So on examination, it was revealed non-exudative tonsillopharyngitis with grade 2 tonsillitis, macular rashes, and mild perianal excoriation. However, there was no strawberry tongue, cervical lymphadenopathy, and coplic spots. So my provisional diagnosis is Kawasaki disease. Point suggestive is because patient's age, which is less than 5 years old, and it fulfills criteria of Kawasaki disease, whereby patient age less than 5 years old with bilateral non-purulent conjunctivitis, mucosal changes of oropharynx, evidenced by injected pharynx, red lips, and dry fissured lips. Got rashes, perianal excoriation, induration of BCG site, and diarrhea. But the points against is the fever is not more than 5 days. There is no edema or erythema of the hands or feet, no discrimination of feet or hands, no strawberry tongue, no transient arthritis. My differential diagnosis is first is scarlet fever. Point 4 is the fever is more than, point 4 is there is URTI symptom, non-exudative tonsillopharyngitis, and there is bright red mucous membrane. But points against is no sandpaper-like rash, no strawberry tongue, no erythematous cheeks, and also the fever is not more than 5 days duration. Fever, second differential diagnosis is measles, because the child have fever, cough, maculopapular rash, non-purulent conjunctivitis, and the child is not yet vaccinated for MMR vaccine. Next differential is roseola infantum. Point suggestive is fever, maculopapular rash, conjunctivitis, and cough. Next differential is dengue fever, because there is fever, loose stool, and also rash. That's for my differential.
Okay, good. So Najila Jamaluddin, what good about the presentation?
I think Norina covered well about the differential in the history of presenting illness, as well as the description of the lesion also described well and thorough.
Okay, good. Okay, Ashraf Khalid.
I think very good because she mentioned several diagnoses, and also especially for viral exanthems. So she will out measles, scarlet fever. So I think, and also dengue. So I think it's good.
Okay, Aimi Soleha.
Good presentation. Dan sama je lah macam dia orang.
Anything can be improved?
Anything, okay. Jadi, I would like to reconfirm. Norina stated that there is a loose stool, kan?
Yes.
Ada blood tak?
No blood, just only the greenish color and watery with mucus.
Okay.
Okay, good. Izzatul Husna, anything can be improved?
I think the same from same comment from my critique just now, but can we add since patient having a fever, can we add also one of the differential is lepto?
Sure. Yes, you can, but you need to justify lah. It's okay because fever it can be anything. Okay, but the theme, okay, basically the theme of the presentation is fever with rashes. Kan? That's the main presentation, kan? Or is it fever with diarrhea?
Fever with rashes.
Fever with rashes, kan? Then, is it typical for lepto to have fever with rashes?
No.
Then you should not put lepto lah in your diagnosis. Okay, so you need to understand. Okay, a good presenter, kan, and even a good doctor is a doctor that understand the case. They know what is important in the case and what is not important. What is what we call red herring. Okay, red herring are things that is distracting. Okay, that distracting you away from important lah, from the primary issues. So in this problem, in this case, the issue is the diagnostic dilemma of a fever with rashes. Okay, that's the theme. So any differential or any working diagnosis should focus on that. So anyway, this is very good presentation. The way it's described is, the way the rashes been described is very good. The loose stool is also very good. How you quantify the loose stool. I'm not sure whether this is you or the case write-up. The way how the case write-up. Okay, that's a problem with case. Presenting a case write-up, because case write-up is something that you retrospect and you write out. So you've got plenty of time to actually rearrange your word, pick the best word to describe. But anyway, this is very good. This is the way how you should describe the rashes. Rashes episodes should be described like this. So the way how it progressed, the distribution, the nature, the characteristic, the associated symptoms, these are very important. And then the flow is very good. Along the presentation, you also sell what you are thinking. Macam Kawasaki kan, we know what you're thinking. So because associated with the rashes, you mentioned there's no eye discharge, there's no BCG induration, which is a typical presentation kan. When you don't think about Kawasaki, definitely you won't present the BCG kan. Okay, it's not typical for someone to talk about rashes, fever, rashes, and then suddenly BCG come in place. So that's not a typical presentation. So it shows the thought process. That's very good. Okay, a good presentation shows that the presenter is thinking, rather than you just bluffing or you just burst with sentence without thinking lah. Okay. And then the loose tool is described well. Okay, very good. The way it's quantified lah, tak overflow. More than 10, 20, I can't remember, but that's the numbers are, the numbers is there. However, okay, I think the summary can be improved. Okay, the summary can be improved. Okay, because the summary, I think it's a bit haywire sikit. Dia macam campur. It's not like the history. The history is very good. Okay, it's very clear, but the summary is a bit unclear lah. And then the PE findings kan, because when you describe the rashes in your history, it sounds like maculopapular. Kan? Maculopapular rashes kan. Tapi when you summarize, or in your summary, I think in your summary you've mentioned macular rashes. Your summary ke atau in your PE you mentioned macular rashes rather than maculopapular rashes. But the rashes, the description of rashes is very good. I can imagine what the rashes looks like. For example, you mentioned about the blanching kan. The way you mentioned, you don't use the word blanch, tapi you mentioned the Scarlet by on pressure kan. Macam mana you mention? That's very good lah. Macam you cakap tadi?
The rash disappeared when pressure was applied.
So disappear with pressure. So that's a good way to describe blanching kan. And then sandpaper like rashes. That's a very typical description of pneumococcal punya rashes kan. Overall, that's very good lah. That's very good. So differential definitely lah, from the history. I can go against it lah. It's definitely a Kawasaki from history. But again, can be other differential. Anything under the sun that cause fever with rashes can be the differential lah. In fact, dia berapa bulan pula ni?
8
bulan kan. So you boleh sebut measles or German measles, rubella, semua boleh lah. Boleh. Definitely dia ada typical punya disease cause kan. Tapi in this case, rashes datang day berapa? Day 2 kan. Day 2. And then fever high grade.
Fever high grade 39 at home.
And then fever settle with the appearance of rashes ke? Itu tak berapa clear. I think that one is a bit not clear lah, fever now.
Okay.
Okay, fever you can clarify better lah. Because problem with fever with rashes kan, there's a lot of differential. So you have to be very precise in your description. Okay, contoh you boleh mention, you boleh start dengan fever. It's okay to start with fever. And then you mention on top of the fever, you boleh sebut the fever peak at day 2 of illness, but subsided with the appearance of rashes. And then you sambung lah rashes. The rashes, blah 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 blah. Okay. Otherwise, differential is all infectious. You boleh mention anything. Okay. Okay, ada soalan?
Doctor, for the differential diagnosis, less likely, but can we put drug reaction?
Yeah, sure. Of course boleh. Tapi apa you punya culprit?
That for this case, no culprit lah. Is the points against.
Okay, boleh. You can say drug reaction. Okay, cuma usually drug reaction dia akan ada history of exposure to certain drug lah. Okay, and remember, drug reaction is usually not what type of hypersensitive reaction that cause drug reaction. Drug reaction ni ada banyak You boleh ada allergic reaction caused by type 1 hypersensitivity reaction kan, IgE mediated, or it can be non-IgE mediated, contoh macam complement mediated ataupun type 4 drug reaction. Some drug reaction can cause type 4 reaction. Contoh macam Steven Johnson kan. Steven Johnson is a drug reaction juga, tapi it's a type 4 hypersensitivity. So it's delayed. Okay, it occurs usually after 2 weeks of exposure. Okay, so you can be specific lah. Okay, kalau you nak kata rashes because of drug reaction is usually type 1 hypersensitive reaction, it occurs almost immediately upon exposure. So kalau tak ada exposure, then you tak payah cakap lah. Lagi?
Doktor, saya nak tanya, I just would like to confirm, betul ke kalau dalam Scarlet Fever, dia punya lymphadenopathy usually painful, tapi kalau Kawasaki dia painless?
That's a good question. Kawasaki dia memang painless because Kawasaki is a vasculitis. Dia should not cause painful lymphadenopathy. Scarlet logically it should be painful. Okay, because it's infectious kan, it's a reactive lymphadenopathy, it's usually painful. Any viral infection, that's why if you got a patient who came with lymphadenopathy kan, one of the clue that differentiate whether this is inflammatory causes or this is an infectious causes. Infectious causes usually will become inflamed lah, dia akan painful. So I assume Scarlet should be painful lah, logically dia painful, but I'm not sure lah, you can check. Tapi Kawasaki is a painless.
Okay, thank you, Doctor.
Lagi?
Doctor, for the Kawasaki, the complication is the coronary vasculitis. So should we mention it, although it's only fever for 4 days?
Macam mana?
The complication of Kawasaki is one of it is coronary vasculitis. So how do we mention in history? Is that no symptom of heart failure ke? Macam mana?
Okay. In Kawasaki kan, the coronary vasculitis, the presentation of coronary vasculitis is aneurysm. Okay. Coronary aneurysm in Kawasaki, it occur at the late stage of the disease. Okay, kalau you biar kan, and this very bad persistent continuous inflammation, you can get coronary aneurysm. If it is too big, then you can get symptoms from it. If not, usually you don't get anything. Okay, but rather even if it is too big, usually you don't get failure symptoms. You will get thrombosis. You get thrombosis or embolic phenomena lah. You dapat stroke, DVT, stroke lah kalau the coronary kan. Coronary, then you should get stroke lah. Okay. Tapi kalau dia besar sangat, you can get failure symptom. But again, the symptoms is later. Most of them is no symptoms lah, dia tak symptoms. They can get sudden death, tapi biasanya no symptoms.
What about a typical Kawasaki disease? Because it can present with the renal impairment, so we should mention also right about the urine pump in the history.
You can lah, but it's very rare lah. It's not common untuk Kawasaki, even atypical Kawasaki pun. It's not common untuk them present dengan kidney punya problem. It's usually liver punya problem, because you have to understand Kawasaki is a what size vasculitis? Is it small size, medium size, or large size?
Medium size.
Arteritis. So it's a medium size kan? That's why they affect your coronary. Faham tak? Coronary artery is a medium size vasculitis. Kidney punya vascular, kidney punya vessels and artery, kidney punya artery is a small vessel. Okay, it's a small vessel arthritis. Apa contoh small vessel arthritis yang you tahu in pediatric? In general, pediatric ni ada 3 je vasculitis yang you kena tahu. In fact, 2 je yang penting. Lagi satu tu tak penting pun. The small arthritis kan, small vessel vasculitis atau small vessel arthritis ni is apa dia? Inox colon purpura, HSP. Okay. That's the only one yang akan datang in pediatric lah. Kalau adult you banyak lagi, tapi in pediatric in general small vessel disease is HSP. That's why HSP, apa complication HSP?
Renal,
Renal kan, lagi kat mana lagi HSP representation?
GI.
joints,
Abdomen.
GI,
joints,
abdomen lagi, joints. More important than that, the most common is
Purpura.
cutaneous kan, capillary, cutaneous lah. The small arterioles dekat you punya tangan ni, these are the one affected first. Because they are small arteries. Okay, so and then medium size vasculitis, you ada Kawasaki. So they affect mana Kawasaki? Dia akan affect you punya mucosa lah. It's quite medium size, it's not very small. It's quite medium. It's deeper kan daripada you punya cutaneous. You boleh dapat rashes, tapi rashes you bukan purpura. It's not a purpura. Because it's a deeper punya vessel affected. So you get all these rashes. It can be any rashes, okay? In Kawasaki, it can be any rashes except vascular, okay? Except vesicles. You cannot get vesicles in Kawasaki because vesicles, the pathophysiology is totally different than the rashes. Okay, but usually it's a maculopapular rashes or any type of rashes can be in Kawasaki. And then you get, because it's a medium size, you get coronary punya problem. And then the third one is you punya large size vasculitis. The most common would be Takayasu lah. So in pediatric ada 3 je. You ada HSP, Kawasaki and Takayasu. Takayasu is very rare lah. I tak pernah jumpa lagi dalam dunia ni. Ada satu patient I suspect Takayasu tapi I tak pernah jumpa. It's very rare in pediatric. In adult is more common. Tapi in pediatric kalau large vessel biasanya Takayasu lah. It's very rare. You tak fikir pun. Even you tak tahu pun tak apa. Okay. That's why if you understand the pathophysiology, then you can predict lah what the presentation would be. And then if you know, if you can predict the presentation, then it can be turned around. So kalau patient datang with presentation suggestive of vasculitis kan, dia boleh tengok, oh vasculitis ni nampak macam medium vessel. So you boleh tahu, oh ni mesti Kawasaki. Faham tak? By understanding the basic pathophysiology, physiology, then you can explain why a certain phenomena happen. Faham? Sama juga macam nephrotic syndrome. You won't mix up nephrotic because up to now, even specialists will mix up nephrotic and nephritic. When the management is totally different. Okay? Nephrotic, nama macam sama tapi it's totally different disease by itself. It's totally different. It's not related at all. You cannot get nephritic and nephrotic at the same time. And the management will be totally different. It's the other extreme altogether. So even specialists will salah because if you don't understand the pathophysiology, you cannot explain the disease mechanism, then you won't be able to differentiate them. Okay, faham? Okay, ada soalan?
Doktor, kalau untuk treatment Kawasaki ni, kita bagi patient IVIG ke doktor?
Yep.
Ada macam kat PLIS protocol ada maintenance bagi oral aspirin. So do we give together or after complete IVIG?
Dia bagi after IVIG. It's basically you give anti-inflammatory lah. Give anti-inflammatory. Because it's autoimmune kan. It's inflammatory vasculitis is autoimmune. So you bagi IVIG. And then kalau you tak ada IVIG, you boleh bagi metapred. You boleh bagi prednisolone, high dose prednisolone. Then you follow up with aspirin. Because aspirin is anti-inflammatory kan. So to reduce the inflammation further. Sampai fever dia subsided. Okay. Or unless kalau patient tu ada aneurysm, then you kena bagi longer term lah. Because aneurysm, what is a complication? Because initial part, okay, the initial part you bagi aspirin as anti-inflammatory. Okay, once patient dah tak ada demam, which means there's no inflammation lah. Kan, evidence of inflammation is fever. So bila tak ada demam, then you know there's no inflammation. Then, tapi kenapa you continue bagi aspirin? In what case yang kena continue bagi aspirin?
Moderate to
Persistent.
severe
Moderate to severe what?
aneurysm.
Ya, kenapa aneurysm you kena bagi aspirin?
Tak nak dia worsen, tak nak dia progress ataupun rupture.
Kenapa dia nak progress? You stop the inflammation kan? Dah tak ada fever, so tak ada inflammation lah. So kenapa you kena continue? That's why the initial part, we call induction part, no, is for anti-inflammatory. So the dose is higher. Okay, subsequently, you just bagi anticoagulation punya dose. Sebab complication of aneurysm is apa? Virtuous triad. Mana virtuous triad? Apa dia virtuous triad? What are virtuous triad? Dia ada triad kan? So ada 3. Apa dia?
Hypercoagulability,
Okay, lagi?
abnormal blood flow, stasis or
Stasis, hypercoagulability, lagi satu?
endothelial injury.
Apa dia? Endothelial injury. So stasis, endothelial injury dengan hypercoagulability kan. Dia ada stasis ataupun you ada turbulence lah. Dua-dua pun boleh. Okay. So this virtuous triad ni untuk apa? What is virtuous triad?
Thrombosis.
These are risk factor for thrombosis. Kalau you ada aneurysm, what happen?
Stasis, blood.
Dia tak stasis, dia ada turbulence.
Tu.
Just imagine you ada pipe kan, tiba-tiba besar. So air dia pusing kat situ kan, and then dia jalan. Pusing. So the turbulence can actually cause thrombosis. And embolism or thrombosis. Thrombosis lah. So you can prevent that by anti-inflammatory, by anti-platelet dose. So you bagi aspirin for anti-platelet, and then you continue sampai lah dia resolve. Because now inflammation dah tak ada, so hopefully it will resolve by itself. So while waiting for it to resolve, you bagi anticoagulant punya dose. Anti-platelet punya dose, sorry. Okay, ada soalan? It's interesting kan, kalau you understand the pathophysiology. Untuk undergrad kan, the first 3 years of life, you just need to understand the pathophysiology. That's it. Later on, baru belajar management. Then you can fuse all the knowledge together. It's what we call coherent theory. Yes, the theory of learning. Theory of learning nama dia. The memory, theory of memory. Okay lah, anyway, so ada soalan? Okay.
Doktor, for Kawasaki, kalau first line, okay, macam first line investigation kita nak buat, terus buat echo ke?
Macam mana?
Yang first line investigation.
Untuk apa? Kawasaki?
Kawasaki.
Yeah, echo is the first line investigation. Cuma remember aneurysm, it may not appear early. So usually you have to repeat. So you buat echo during the acute stage, and then later on after the second week, you can repeat echo. Because it may not appear. Kalau you buat the first week dah ada aneurysm, then that's a very bad prognosis lah. you kena start treatment cepat. You may need to give steroid pun untuk fasten the to stop the inflammation. Tapi kalau first week tak ada aneurysm, then you can repeat at the second week. Okay, kalau baru and then second week ada aneurysm, then you treat as aneurysm lah dengan antiplatelet. Okay.
Okay, thank you, Doktor.
Okay, thank you. Okay, ada lagi? Kalau tak ada, kita dah stop. Okay, so I bagi markah. Boleh I bagi 7 dengan 8. Okay, I bagi 7, Nurina 8. Okay, so next time boleh present orang boleh present. Okay, kita tanggungan tasbih kafarah. Suratul As.
Thank you, Doktor.
Thank you,
Okay,
Doktor.
thank you.
Thank you, Doktor.
Okay.
Thank you,
So-
Doktor.
Okay, thank you.